opportunity. I'm pleased to introduce Dr. Mark Komrad, who is a psychiatrist on the teaching faculty of Johns Hopkins, as well as a professor of psychiatry at the University of Maryland and Tulane University. And he's long been a supporter of NAMI and has been recognized by NAMI. He's done these types of programs for NAMI Maryland and NAMI Metro Baltimore for the past 2 decades. And he's been the honored recipient of 2 NAMI awards for Mental Health Professional of the Year, as well as Exemplary Psychiatrist. So we're very pleased to welcome Dr. Mark Komrad. If you have questions that you'd like to ask, and we encourage you to do it, please post them on the social wall, and then we will take those questions. There may be a 20 to 30 second delay between the time that you post them and the time that you see them up on Conference Tracker, but we will try to get to all the questions that we can in this session. And so now I'm going to turn it over to Dr. Komrad. He's going to tell you a little bit about his experience, and then he'll be ready to answer questions.
Thank you so
Komrad?
much. Thank you so much, Linda. And my regret is that I can't see any of your faces. I've been doing this actually for NAMIs all over the country, but this is my home NAMI. And NAMI actually is one of the most important tools in my toolkit. It is not unusual for me to take out my prescription pad and write attend NAMI family-to-family support group, or another NAMI function that I hand to either a family member or patients. And so NAMI in many ways is my secret weapon, but which I would like to make less secret because I think it's a tremendous resource. I usually really enjoy seeing your faces and being amongst you. So at least in this time of COVID, it's nice to have the technology to have an alternative way of communicating, albeit once removed. And you'll have to write your questions, and then the moderators will get me those questions so that I can answer them. Meanwhile, while we're waiting for those questions to come in, I guess I should tell you a little bit about myself. I am a psychiatrist now of 38 years. I did my residency training at Johns Hopkins. And over the course of many years, I've been involved in several things. One is I've always had a private practice of psychiatry where I've had a special interest in schizophrenia and mood disorders, personality disorders. But also for many years, I helped to run the treatment-resistant psychosis unit at Shepherd Pratt Hospital for many years. And also, I have kind of a couple of other manifestations in my career. So one is I am a medical ethicist. And in fact, I chaired the ethics committee and the ethics consultation service and was the ethicist for the Shepherd Pratt Health System for many years, for about 25 years. I did that and have been involved in writing and teaching about ethics conundrums and challenges that come up in behavioral health and mental health and psychiatry. So that's one other aspect of my career. And the other is I have done a lot of public education, and perhaps the most significant of which was back in the late 90s and early 2000s, I had a radio show. And my radio show went coast to coast. I had about 13 million listeners. It was on the American Radio Network. And then later I transferred to NPR and appeared on other people's show. But my show was called Komrad on Call. And in Komrad on Call, it was a 2-hour live radio talk show in which usually the first hour, I'd interview a guest and we'd take calls. And in the second hour, it was typically open phones in which people could call and ask me any question about psychiatry, medications, therapy, the mental health system, the brain, pretty much anything that is somehow connected to my wheelhouse. So frankly, those open phones were a much more popular part of the show. And in many ways, I would compare what we're doing here to kind of the open phones sessions that I used to do, where I just field whatever questions would come up. Interestingly, one of the most common questions that came up repeatedly over some years was something like, I have someone in my life, my parent, my child, my best friend, my grandmother, my sister, my husband, my wife, who is clearly troubled. And they're more trouble than I know what to do to help them. And I'd really like to try to convince them to consult and get evaluated by a professional like yourself. How do I go about doing that? And so brainstorming with people about that over hundreds of calls, frankly, because it was a pretty popular question, I ended up developing a special interest in that topic. And people, because of my being known nationally, people came to consult me from all over about that question. And I started to make that kind of a specialty, special interest of mine in my practice. And after about 20 years of doing that, I decided to put everything that I had learned into a book. And the book, which I will now self-advertise, is called You Need Help, a step-by-step plan to convince a loved one to get counseling. And I'm very happy to say that this book has been very wonderfully embraced by NAMI, who uses it in most of their family-to-family courses. And as a matter of fact, it's interesting, there's another book that many of you might also be familiar with by Javier Amador, who's another big mental health professional, psychologist that does a lot of programs for NAMI. And his book is called I'm Not Sick, I Don't Need Help. And that really addresses especially the more severe end of the spectrum for people that don't have any insight into their illness. So NAMI several times has called that book and my book the two bookends of NAMI, right? You need help, and I'm not sick, I don't need help, that are very complementary. So that arose out of my media career. And the last thing that I'll share with you about myself is that I have long been interested, particularly in my role as an ethicist, in how Hollywood depicts both people with mental illness and those who treat them, and some of the distortions and stereotypes of psychiatrists like myself. And I have done a lot of work and lecturing and writing about that issue. And it ultimately resulted in several opportunities that I've had to be a consultant for Hollywood movies to help them get more accurate portrayals of both people with mental illness and those who treat them. And that's been quite interesting. I've been involved in several films. And as a matter of fact, there's even one film in which I ended up playing the role of a psychiatrist. I suppose that was inevitable if I was hanging out on movie sets for so long. So that's kind of an overview of my career and my background. And as I have been doing that, questions have started to come in. And I think we have a couple of questions to begin with, and I'm going to turn it over to Linda to start with our first question.
All right. Danielle wants to know, how has your work changed during the pandemic?
Well, I think that's a great question because it certainly has changed. And indeed, I think anyone paying attention certainly sees how the landscape of mental health has changed considerably during the pandemic. And I did a program for Maryland NAMI on just that. So somewhere on the Maryland NAMI YouTube channel is a program that I did at the beginning of the pandemic about how it was affecting both those who already had mental illness and those who, who have not yet had any help, but were now ready or needed it more than ever. In terms of my own work, obviously it is much busier, and it has transitioned almost entirely, well, certainly for a while entirely, but lately some exceptions, to telehealth. And telehealth has been a very interesting experience for me. This technology has been with us for a long time. And, why weren't we using it before? And frankly, I really sort of rejected this way of connecting with people prior to the pandemic. But since it became a necessity during the pandemic, I've actually come to embrace it and wondering, what was I thinking? Because there are some great advantages. I mean, a couple of simple things. One is that you don't have to wear masks. You don't have to sit together and wear masks. So we can meet, without that obstruction. And frankly, I think there's much more openness to that, and frankly, much more information from nonverbal cues, facial things, both ways, both from me and from the patients that I'm treating. Secondly, it's been a tremendous convenience. I have patients who have often drive quite a distance to see me. Some of them 2. I even had one patient who drove 3 hours. Patients who had to find time to take off of work in the middle of the day if I didn't have evening appointment available, and so forth. And now the convenience of just meeting me right from their home, or sometimes if they need privacy from their car, I think has been interesting. Also, being able to experience people in their homes, I think, has been very interesting. It's in many ways, it creates a little bit more of an intimate connection. People are figuratively, not literally, having me into their homes. I see their pets, their cats, their dogs, their kids. Their spouse walks by. Even though we're supposed to be, confidential. I mean, sometimes, patients don't care. The spouse walks by and says, "Hi, Dr. Komrad." So gotten to meet, people's significant others and their kids that way, and seeing interesting things like the art that they have, or the books that are on the bookshelf in the back, and other kinds of things. It's been especially good, I think, for younger people, because I think younger people are especially more used to these kind of venues. I think it's been some other challenges that have happened during the pandemic is it has been much more difficult for people who are very ill in certain ways. First of all, when people have some symptoms like paranoia, right? It's very difficult for them to trust that they're not being, watched in other ways in online sessions. It's been very difficult to access certain resources because of the pandemic. The hospitals have been very difficult to access because, number one, many of them weren't taking as many patients, especially early on in the pandemic, because of the risks. And number two, because of the increased demand and the way in which the trauma of this time has both exacerbated existing illnesses and brought on new ones. They're very crowded. And in particular, the step down resources that come after hospitalization, namely day hospital, partial hospital, intensive outpatient care, have either been offline, in which many of them just shut down for months and months and months during the pandemic, or online. And when people have the level of acuity where they need that level of intensity, daily online day hospital that goes on for 5 or 6 hours for a day is very, very difficult for them. So that resource, which I often depended on when patients were too ill to really be managed appropriately by meeting with me once a week or twice a week for an hour, those things became increasingly difficult to access for me. So those are just some ways that my practice has been affected by the pandemic. Maybe other ways will come up as we continue to look at questions. All right, next question.
Well, the next is actually just a comment. So it's a very nice one. I am so excited to attend this workshop. That was from Alita.
Thank you, Alita. I'm excited to have you. I wish I could see you.
I know. The next one is a really specific question, but a very interesting one. It has to do with people who have security clearances. So the question is, do you see any changes in the near future between mental health and the military? There seems to be some issues with airmen with security clearances reaching out for help without losing their clearances. It's very sad.
Yeah, this is a very challenging thing. So first of all, let's just say that mental health problems in the military are quite significant. In the last 5 years, we have lost almost 10 times as many people to suicide in the military as we've lost in any kind of a combat situation. And there is actually quite an epidemic of suicide in the military, and and suicide attempts by people in the military or veterans are much more likely to result in death. Why? Because this is a population that's very likely to own a gun, and the far and away the most lethal method for attempting suicide is a gun. Far and away more lethal than anything else you can think of. Pills and hanging and even jumping. This is, frankly, a little aside here. People worry about guns and violence. The real story when it comes to guns is guns and suicide. The fact of the matter is that 2 out of every 3, 66% of every human being that dies at the business end of a gun, their own finger is on the trigger. So 2/3 are suicides, only 1/3 homicides. So, everybody's always talking about, guns and murder and homicide, but in fact, a much more significant and common story is guns and suicide. And you can see how that interfaces with the military. Now, in terms of security clearances, and I might make an analogy here with other similar kinds of circumstances. We actually have similar kinds of concerns in the medical profession, in which when you apply for a medical license, you're asked about a history of mental illness. Now, in places that are very enlightened, in states that are very enlightened, they go on to say, do you have a condition which currently could interfere with your ability to practice medicine? So a lot of people who are doing well and taking medications and treatment and so forth can honestly say, no, at the moment, I don't have anything that will be that is currently interfering my ability. But saying that you have a history in some states is enough to get you into some real trouble, both getting a medical license and renewing a license. And so it is with security clearance. And that seeing that there is a history of treatment or being on a medication, particularly a psychiatric medication, sometimes interferes with security clearances. Now, being proximate to Washington, D.C., I treat a certain subset of patients who have security clearances. And so I've been involved in some of these screenings. And those screenings typically involve an interview with me, sometimes over the phone, sometimes in person. And generally, I have found those interviews to be fairly, to be fair, in which what they're much more interested in is a person participating in treatment? Are they cooperating with treatment? Is there any aspect of your treatment plan that they have not been cooperative with? And do you see, anything in the set of symptoms that they have that might in any way make them unable to keep secrets, deploy confidentiality where necessary, and anything that you would see that puts them at risk for violence. So it's not just, do they have a psychiatric disorder? It's, okay, they have a psychiatric disorder, that gets you in the door to have this conversation with me. But then they want specifically those detailed things to be addressed. So I do think that, but I certainly understand that there is an inhibition to reaching out for help, because people worry that they won't get or will lose their security clearance, much as there is in the medical profession reaching out for help people feeling like their licenses would be jeopardized. The American Psychiatric Association, in which I'm very active, has been very active in trying to advocate in these kinds of settings, in national security settings, in state licensing boards for healthcare professionals, about some guidelines for what we would consider appropriate and careful and thoughtful approaches to evaluating, because these things should be evaluated, they have to be evaluated, but to do it such a way that minimizes stigma, minimizes inhibition to getting help, and yet at the same time serves the needs that to protect the community in these ways. So that's hopefully that's helpful in understanding this situation for this questioner. I want to say caller, I'm thinking of open phones. All right, Linda, let's move on. Wait, something's happened, Linda. You put yourself on mute.
I did.
Okay.
I have two questions that I'm going to combine because they both get to the same issue. Any suggestions on how to deal with the workforce shortage of psychiatric providers and prescribers, and most importantly, getting providers who represent minority populations? That's from Susan. And then Lisa asks, how can we encourage others, especially people from underrepresented groups, to go into the field of psychiatry?
Right. This is a very interesting and important question. As a matter of fact, this is something that I just mentioned, the American Psychiatric Association, which is our large professional organization, has absolutely been wrestling with. This is definitely a front burner issue that the organization has been tackling. So look, in general, there's a shortage of mental health professionals, just across the board, and particularly of psychiatrists. Why? Psychiatrists in particular, well, I mean, it's a very long haul to become a psychiatrist, right? First, you have to go to 4 years of undergraduate school. Then you have to go to 4 years of medical school. And then you have to do 4 years of a residency, 1 year in internal medicine and 3 years in psychiatry. And then if you have an additional specialization, like want to be a geriatric psychiatrist or a child psychiatrist, or a forensic psychiatrist, then you have an additional 1 or 2 years. So by the time you're kind of fully minted and ready to get out into the world, we're talking 12 to 14 years of your life dedicated to that, and a considerable cost, right? And because college is not free unless you're lucky enough to get a scholarship, and med school is very expensive, and they don't give scholarships to med school. And then, of course, residency, is not particularly highly paid. So there's a great deal of sacrifice that goes into that. Also, there are a limited number of residency training positions. The federal government actually controls the number of residency positions that any medical school is allowed to offer. And because it helps to fund them. All residency training programs are partially funded by the government. And so, like all things that have to be funded, the government has limits on what they're willing to pay. So the funnel is very narrow for training psychiatrists. So as a result, there have been others that have stepped into the breach. First of all, primary care people are getting more and more training in mental health. Secondly, advanced practice nurses and physician's assistants are getting training in psychiatry. One of the things, though, that I'm concerned about is in many states, like Maryland, to get an advanced practice degree in psychiatry, in nursing, you have to have 500 hours of training compared to 15,000 hours of training to become a psychiatrist. So it's a tiny fraction. Don't go to medical school, don't do a residency, you have some clerkships. So it's a tiny fraction. And yet, once you are finished with your degree, you have all the identical privileges to practice like a physician psychiatrist. So this is something that is somewhat concerning. And in Maryland, you do not have to have supervision by a physician if you're an advanced practice nurse. So We need advanced practice nursing. They're very important. They do very, very well in teams where they can have collaboration with and access to and supervision by physicians, but that's not often done. So now let's turn to, and is not required in a state like Maryland and 27 other states. Now let's turn to the racial issue. So, there are many reasons why we don't get as many people of color into medical school. Finances actually is a very significant one. Also, the kinds, access to the kinds of educations, private educations, top universities, which both cost money, also require, getting incredibly good grades early on. And we know for a variety of sociological reasons that I'm not going to get into here, that people of color tend to have lower level of academic achievement. Not that they don't have the potential for more, but they may not have access, opportunity, and resources, and so forth. So that's a problem as well. I do want to say that it's become very important and has become now very integrated into training to train all mental health professionals, but particularly my domain, psychiatrists, in to develop some sophistication and sensitivity to racial issues, to deal with structural racism in the programs that we set up and work in and so forth. So I do think that you do not necessarily have to be a person of color or a person of, South Pacific origin to treat a South Pacific Islander in order to be able to be effective. I think you need some additional education and training. So I don't want to endorse the idea that only people of one race can treat a person of another race. I mean, I've certainly treated people from many different races, and I believe in my experience that it's gone very well. But how do we get more people into it? I think here's what I think. I think that underserved areas, if they can manage through their resources, whether it's their communities, their churches, their nonprofit institutions, to be able to sponsor financially a scholarship for people, both undergraduate and medical school, with the provision that the student who receives the scholarship commits to coming and working back in the community that provided that scholarship for at least 5 to 10 years, I think that would actually be a very effective tool that might be, and you could make it available specifically for people that come from that community, whether it's a racially based community, a culturally based community, a religiously based community, so that you can kind of guarantee, and then if you don't come back to service our community, then you'll have to pay back all the money that we gave you. I think that that's a solution that might very well be worth considering to enhance to enrich the presence of people of greater, broader diversity that may come from less privileged backgrounds. All right, Linda, let's move on.
Amy asks, how do you help a person who has trauma and needs long-term care?
Well, Amy, that's a very big question. And, there are so many different approaches and techniques that we have for trauma. And in fact, I actually consider that the special techniques that have been developed for dealing with the trauma, and trauma, by the way, can have a very broad definition, right? From physical trauma to emotional abuse, to sexual abuse, to witnessing trauma in other people, which is in itself traumatic, to moral injury, where you are put in positions where you are forced to behave in ways that are not consistent with your own values. So trauma is a very broad set of a very, very broad clinical domain. And the techniques that have been developed to really focus down into the so-called trauma-informed treatments are many and varied, both in terms of therapies and in terms of psychopharmacology and other kinds of treatments. So much so that I actually think that trauma is increasingly becoming a specialty in its own right, like geriatrics or child psychiatry, or another specialty that, has so many special techniques that, people devote their careers primarily to would be eating disorders, for example. So that's what to say about trauma. Now, in terms of long-term care and treatment, so obviously there's a real need for moving away from crisis-oriented care as our standard model for the kinds of treatments that take a while, that are not just about removing someone from the acute either the danger or distress of their crisis, right? So putting them into treatment relationships that have an opportunity to do deep and protracted work that may take actually some years to do. And I think that it's very important that our treatment systems, both the institutional treatment systems and medical insurance, be able to support those kinds of long-term relationships rather than, we'll give you 10 sessions. Or we'll give you, a crisis visit. We'll put you in the hospital for 5 days, which, by the way, is currently the typical length of stay of an inpatient. When I first started in psychiatry back I guess I started my psychiatry residency in 1984, finished my residency in 1988. The average length of stay in an inpatient psychiatric facility was 32 days, and now it's somewhere between 3 and 5 days, depending on where your jurisdiction is. But of course, now we have step down things, as I talked about before, day hospital, partial hospital, and so forth. So we need to be able to have more robust and enduring systems of care, such as a much longer ability to keep a partial hospitalization going. Residential treatment is absolutely critical. I have to tell you that long-term residential treatment, a full 360-degree immersive treatment where you have in a kind of proto-family environment, you live with other people, you make meals with them, you have therapists and vocational and OT and even integrated into jobs in the community. These programs are absolutely wonderful, and they have turned around some of my most difficult cases over the course of my career. That's the good news. The bad news is they cost an arm and a leg, and insurance typically does not cover them. Interestingly, in the interest of parity and parity laws, if insurance covers, 3 weeks in a step-down rehabilitation hospital after your car accident while you're recovering from your orthopedic injuries, then by parity, it ought to recover more long-term sustained treatment for psychiatric situations. But they typically don't, so they end up, and they're costly. Most of these programs, they start at $15,000 to $25,000 for the first month. Now, the insurance sometimes will cover the doctor visits or the therapist visits, because that's like they would anywhere, but not the cost of your room and board and the other activities, therapists and so forth that are part of it. But that being said, there are a number of these long-term residential treatment programs that have developed a special interest in treating trauma disorders and have a specialty in that. And that's certainly a resource to be aware of that I think is something that, if you can afford it, is absolutely worth considering. And meanwhile, we who are advocates, both professionals like myself and lay people, as the wonderful folks at NAMI and their participants will continue to advocate for expanded financial coverage of these kinds of complex, long-term, and expensive forms of treatment that we need to be able to turn around complicated disorders like trauma disorders, like severe long-term major mental illness, schizophrenia, bipolar disorder, and the like. Linda, on to the next.
Yep. I have a good relation with my psychiatrist, but it was a bumpy road as she was not willing to do talk therapy along with medication management. Why does it seem like psychiatrists are more focused on medications and not talk therapy?
That's an excellent question. And I'll begin that question by saying this psychiatrist does both. I do both psychopharmacology and psychotherapy, and we do exist. But we're not the majority. And let me explain to you why we're not the majority. There are two reasons why we're not the majority. One is, of all mental health professionals, we are the only physicians. And therefore, we are the only people that are really equipped to take on complicated cases, think through complicated differential diagnosis. Is this a brain tumor? Is this an endocrine problem? People who have so-called comorbid medical conditions or substance abuse conditions that have tremendous physiological and medical consequences. And we're the only mental health professional who, thanks to 15,000 hours of training, can prescribe, state-of-the-art psychopharmacology. So, and there are many other kinds of mental health professionals, psychologists, social workers, other kinds of counselors who are capable of providing the other kinds of therapies that are helpful for the treatment of these disorders. So, if you can imagine, if psychiatrists are a scarce resource to begin with, and there are a lot of people that need the kinds of both evaluation and treatment that only a physician psychiatrist is trained to do, that is going to definitely put a lot of pressure on psychiatrists to do just that piece of it, right? And to have to split the care. And unfortunately, that does lead to a certain amount of fragmentation, where if other forms of therapies and talk therapies are needed, which they typically are, that you'll get into a position of having two professionals and hope that the two professionals are communicating with one another, and that the left hand and the right hand are shaking and know what each other are doing and not working at cross purposes and can, advise and inform one another. And frankly, for those patients, and I do have patients who have therapists, it's not that I have none. For most of them, I'm the therapist too, but I have some who have therapists. I only work with therapists with whom I have a close collaborative relationship where we communicate, and that takes a lot of extra time, right? Imagine that if you're billing insurance, okay, there's actually not a way to bill insurance to have long conversations between two professionals about their mutual patient, and complicated patients take a lot of time. So, I may spend a half an hour speaking to a patient's therapist about the case periodically, and there is no insurance coverage for that kind of thing. And we psychiatrists and most mental health professionals are still one of the few professionals in medicine left that actually are linked to time as the primary resource that we have that people pay for. And so a half an hour, is a lot of time. Team meetings and things like that are a lot of time. So that's one aspect. The other aspect is that, frankly, insurance does not pay nearly as well for an hour of psychotherapy as it would pay for 3 patients being seen for 20 minutes each, just for medication check and evaluation. So you can, if you're trying to make a living, it's much more favorable to treat 3 patients with med checks than it is 1 patient with psychotherapy. Not to mention the fact that we're the people who have expertise in med checks. It's one of the reasons why psychiatrists like myself who want to do both, to be one-stop shopping, both therapy and meds, because I enjoy it and I feel that, especially for complicated cases, that really is in the best interest of the patient to not have fragmented care. So psychiatrists like myself do not take insurance. And that's why I don't take insurance, by the way. I do not take insurance because I want to be able to spend an hour with a patient. I would say most of my patients see me for an hour, and maybe 30% see me for a half an hour. And we're talking about a lot more. We're doing a lot more than just, how's the medication, any side effects, or how are you sleeping, how's your appetite, are you losing any weight, let's take a blood pressure. So we're talking about many things and doing that. But frankly, it would not be it would not be sustainable for me based on what insurance pays for psychotherapy to spend an hour with patients like that and take their insurance. So there is a high correlation. This is not universal between docs that don't take insurance and yet also provide psychotherapy. That's healthcare in America today, because time, is our most precious commodity for which we are billing. So I hope that goes over some of the fundamental things that go into why we see these kinds of splits. All right, next question.
The next question is from Alita, and it's about telehealth. She says, I love my therapist, but I think my therapist hates telehealth and audio type sessions. Before COVID-19, she was very alert and a rock star. Do you think some therapists are not doing well with the latest Zoom and phone therapy sessions? How can I help her?
Yeah, I think the answer to that is yes, absolutely. Just like there's some patients that aren't doing as well with telehealth. There's some therapists that aren't doing as well with telehealth. So, so first of all, you might want to say, how critical is it that we do telehealth? Is there any other alternative? So right now, I am inviting patients who are vaccinated and not ill to come to my office, and we'll wear masks for an hour if they wish. And some people say, great, I definitely want to do that. Mask me up, I'll sit with you for an hour. And other people say, it's so nice to not wear masks on telehealth, or it's so convenient for me for reasons that I talked about in the first question, as to why people like telehealth. So you might want to ask, is it possible, could we meet in masks? Because now in this era of vaccination, a number of my colleagues are going back to seeing patients in the office with masks and other kinds of, usual precautions, hand washing and social distancing. If you come to my office now, the distance between my chair and the patient's chair is about 50% further than it was before the pandemic. And I also have a window open in the one wall, and a window open in another, and a fan that blows a breeze from one window to the other, so as to create a cross current. So you might want to ask your psychiatrist, is that possible for them? Secondly, there are different kinds of, there's sort of 2 fundamentally different kinds of telehealth, right? One is video telehealth, and the other is phone telehealth. And I think that some patients and some treaters are much more comfortable with and more likely to thrive with one technology or another. So if you're doing video, you might say, let's give telephone a try. Or if you're doing telephone, let's give video a try. And then the final idea that I have is, look, it can be, we're all learning the term. It might even have made it into Webster's dictionary this year, Zoom fatigue. We're leading our lives, our schooling, our work, our family relationships on Zoom. And, for people who are working on Zoom, many, many hours of the day are spent Zooming, and it can be very fatiguing. So another possibility to ask is it possible for us, if we're doing an hour, can we do 2 half-hour appointments? Can we do, a half an hour on one day and a half an hour on Thursday? Because it is fatiguing, maybe for both sides of the screen, and perhaps a different kind of format of that nature. And finally, one more idea, because I'm doing it, especially now that the weather has turned nice. And that is, I have an alternative on a nice day, and that is a strolling session. Actually, I have a little park down the street from my office. So I say, okay, we have 3 choices. We can do telehealth, phone or video. We can sit in the office with masks, or we can stroll and sit on the park bench, or stroll around. I happen to work in a nice little residential neighborhood, so I don't know if this would fit this particular person's psychiatrist. But and we walk and talk, which is great. Back when I was doing all those years of inpatient work on the psychotic disorders unit at Shepherd Pratt, a very common thing that I would do with my patients with severe schizophrenia, they tended to open up and relax a lot more if we went outside and strolled around the Shepherd Pratt campus while we met. They actually had a nice path through the woods there. That was before they built this Towson State student housing on the campus of Shepherd Pratt. There was nice woods there. We'd walk around, we'd sit on a couple of logs. So that's another option that you might want to explore with your psychiatrist. All right, Linda, next.
Ina wants to know, what is the diagnosis or comorbid diagnoses which have been the most difficult for you to treat?
What are the diagnoses that have been most difficult to treat? It's a good question. I have to think about that. I think as an outpatient psychiatrist, which really I've been exclusively outpatient for the last 12 or 13 years. So I'm going to answer from that recent experience. I think severe psychosis is the most difficult for an outpatient doctor to treat. It's a very unstable situation. It's often very difficult to get patients to cooperate or to take their medications. Their families are often in a state of high crisis, particularly early on in the course of illness with young adults that are living in their families. Matter of fact, when it comes to people who consult me vis-a-vis the topic of my book, how to convince a loved one to get psychiatric evaluation and treatment, I would say the majority of them are young adults who have clearly a major mental illness, typically with a psychotic component, whether it's schizophrenia or an affective disorder, and have no insight into their illness, have that fancy Greek term anosognosia, where they don't know that they're ill, and may indeed think that all the people around them are the ones with the problems rather than themselves. And these tend to be very difficult cases, involve a lot of family drama to it. And often these people need higher levels of care that they may or may not be willing to get into. And then you have to go down into the rabbit hole of the incredibly challenging and difficult approach to involuntary treatment with, under certain circumstances, with emergency petition and getting them to the emergency room and then having them admitted involuntarily and then going through a civil commitment hearing and possibly, but by then they're in the hospital. And then the complexities of if they refuse medication developing what's called a med panel to go through the due process of overriding their refusal so they can get medication against their will, and it becomes quite challenging. So I would say that people with significant and acute psychotic symptoms. Now, I treat a lot of people who have chronic schizophrenia or schizoaffective disorder, and their psychosis has not remitted completely, but we have it under good control. They're able to function, oftentimes able to work or go to school, even though they continue to be symptomatic. They get along okay with their families. They can care for themselves, and they're pretty stable. And they're not in and out of the hospital anymore, or standing on the ledge, figuratively or literally, anymore. And so the treatment is about both maintaining people and also trying to help maximize their function, continue to grow in their capacities to, as Freud would say, to both live and love effectively, the two great domains in which people have to function: love and work. Love being relationships, and work can also have a very broad meaning. So in my ongoing work with those folks, we're not dealing with acute issues. We're trying to they're on a rehabilitation trajectory to maximize their capacities to function in the domains of love and work. So, and obviously, those are less challenging situations. I mean, they have their own challenges, but somebody who is acutely psychotic, very paranoid, who is, locking themselves in their bedroom, refusing to eat, walking into urgent care centers, demanding that they get an X-ray to prove that there's really something that's been implanted in their brain. Those kinds of things, they're extremely challenging. And you have family meetings, and frankly, for those cases, I need help. My book is called You Need Help. Sometimes I need help. Sometimes I need another therapist involved, sometimes working with the family, or spending a lot of time with the patient, or a case manager who can actually go to the patient's home and so forth. So I end up having to interface with other professionals as well. So that's also part of the challenge of these kinds of acute and severely mentally ill patients. All right, Linda, next.
Here's a very specific question. What drug combo is most effective for an intubation client, unmanageable and violent with extubation ×2? She is now in hospital 7 days and they still have not found a drug to manage her. Trials used Ativan, Haldol combo, Presidex. She is sedated and still intubated on Diprivan.
Yeah. Well, I have to be honest that I do not work in those kinds of settings. And therefore, I will admit that I am not up on the state-of-the-art choices under those conditions. I certainly am familiar with general classes of medications, antipsychotic medications, benzodiazepines, which have been mentioned. Ketamine is actually, a ketamine anesthetic. I think that, look, there are techniques that palliative care physicians are familiar with that they use for so-called palliative sedation. And those where people are put into, very light states of coma or sedation throughout the acute period. And of course, somebody who's intubated, hopefully that's a short-term thing. But I don't know, maybe this is a patient who has a long-term tracheostomy with intubation, like Christopher Reeves, a high paraplegic who needs, ongoing ventilation around the clock. So I think that that's about the best that I can say without pretending that I'm more state-of-the-art in that particular context than I really am. So sorry about that. Let's move on to the next question.
What are your thoughts about how best to advocate for second opinions or consultations for individuals who have been in the state hospital for an extended period of time with no change in their condition? Some of the psychiatrists get very defensive when we bring up the possibility of a consultation or second opinion. Are there any best practices on this issue? We see people confined to their rooms for months on end because they are dangerous if they mix with the rest of the patient population. This is from Lucien.
Yeah, yes, indeed. So, Lucien, as you know, but many others might not, the whole state hospital system, which was originally developed for the poor, for people who could not afford to pay either out of pocket or with private insurance for private hospital care, such as a unit, the psychiatric unit at St. Joseph's Hospital, or the psychiatric hospital like Shepherd Pratt, and they would typically have as an alternative state hospital. Well, some years ago, that system really changed, and many private hospitals were forced to take Medicaid and also to take uninsured patients, which then they got on Medicaid. So this whole state hospital system became transformed into a forensic system. What's a forensic system? Forensics means things that are involved with the law, people who are in legal troubles. So the state hospitals are now a place where you go if you have been convicted of something for which you need to stand trial, and either you are your competency to stand trial and participate in your defense is in question, or in which, while you are waiting to be adjudicated, you are deemed unsafe to be in the community, or both. And the hope is, by sending you to the forensic setting, which state hospitals now are almost entirely, that they will be able to, if you do not have competency or capacity, that they will treat you and restore you to the point where you are now able to go and participate in your legal activities and your hearings, or if you're violent and dangerous, that can be ameliorated and improved to the point where it's safe for you to then go on and be adjudicated. So many people end up staying there a long time without actually having their trial or their hearing. So we can get very long lengths of stay like this. So what if a family member is having some concerns about whether or not the treatment is appropriate, or state of the art, or sufficiently effective? So I think there are several steps that you can take. Obviously, the first thing to begin with is, I think that it's very reasonable for a family member to say, I would like to have a team meeting where I sit with the team and hopefully with the permission of the patient. This is assuming you can get the patient's permission, to sit with the team and really understand what the assessment is, what's the current treatment plan, what kinds of things have been attempted, what other options there are. I'd like to be able to understand that on the behalf of my family members. So to ask for a team meeting. So you'll sit with the doctor, the nurse, maybe the occupational therapist, other possible members of the team. So I think that's one thing. Now, the patient may not give permission for the doctors to speak with the family members. Now, sometimes you can get around that with certain legal maneuvers and so forth, but we won't go there at the moment. So what do you do then? Then I think that obviously you would want to say to the doctor, look, I have some concerns. Is it possible for me to have a consultant to come in and just consult with you. I know you guys can't share anything with me, but to provide an outside second opinion for you as to whether or not there are any new additional ideas that are available. I think that that's a reasonable request. If you ask that and the doctor says no, I'm not comfortable with that, then I would absolutely go over the doctor's head and speak to the director of the institution, the superintendent, the medical director of the institution, and say, I have some concerns about this. And Dr. So-and-so, I've asked for a second opinion consultation. And I don't know, maybe there's somebody else on the staff who could provide it, or maybe, you have a protocol for this, but I'd like to talk with you about this possibility. Then the other approach is, remember, these are forensic settings, right? So by definition, every patient in a forensic setting has an attorney. So working through the attorney who is working with your family member or loved one, and expressing your concerns to the attorney, and having the attorney contact the doctor or contact the institutional head of the department, either the division or the superintendent of the hospital, to say, I, as the patient's attorney, and the family members have some concern about where this treatment is going and how much time it's taking, and how much, quiet room, time people are having, and the isolation. So we would like to have a second opinion. And so hearing that request from an attorney may carry a little bit more muscle than necessarily hearing it from a family member. So those are some of my ideas, Lucy. All right, Linda, let's press on. Although we're at 4:30, I'm happy to continue for a little bit longer, since there are more questions.
We have two more questions. One goes back to the question of how do we get more representation of psychiatrists and other professionals from underserved communities. So the question is, would it be effective to pay off med school loans for people who are willing to work in underserved communities?
Yes, definitely, and that's done. There actually are some communities that will lure people to come work there with all sorts of enticements. So I've actually had residents over the years participate in those kinds of things. I remember one resident where they offered him not just to pay off his student loans, but they gave him a house and a car as well, like a parsonage, right? Come work for our church, we'll give you a parsonage and a church car. So I've seen it. I've seen that happen. Now, of course, a lot of communities can't afford to do that. And there are other things. There's the National Health Service, the Public Health Service, where if you go and sign up to work for them, sometimes on an Indian reservation or an underserved area, they will pay back your student loans. So actually that's done. And there have been some communities that have been able to manage that. Or some hospital systems that are really desperate for help that are willing to do that. So it's a great idea, an idea that is actually alive and well even as we speak. Next question.
I think this is the last question we have, and it's a good one. What do you think of psychedelics and the FDA giving several universities and biotech companies breakthrough status for proving clinical trials with synthetic psilocybin, LSD, and MDMA to alleviate PTSD and addiction?
I think it's very exciting. So just to kind of inform other people that don't know about this, this person clearly does. We're now seeing a number of research centers, one of the most prominent of which is right here in our own state, Johns Hopkins, which is actually also collaborating with Shepherd Pratt, getting a waiver for these so-called Schedule I substances, which is the highest, most regulated category at the FDA, which is strictly illegal and only available for research purposes. So there have been, actually for about 15 years, Hopkins has been doing this, but they just got, I think, a $15 million donation from somebody, as well as grants from National Institute of Mental Health and so forth, to be expanding the research. And we're beginning to see some really wonderful, promising results with certain in certain kinds of conditions. So the most interesting of which, the first condition that they really worked with was people who are terminally ill and are terrified and frightened and overwhelmed emotionally with their terminal illness. And it seems that one session of treatment, and we'll talk about what treatment means in a second, a single session of treatment had a profound and enduring effect on some of those kinds of existential fears and preoccupations for months and months and months. So that gave them the idea of, why don't we try it with people who have treatment-resistant depression? And again, 1 or 2 fairly low dose treatments with psilocybin, which particularly talks psilocybin, low dose, so that only about 20% of people get kind of a trip, and 80% of people don't so much, get really tripped out by it, has been able to effectuate a remission of depression in people who have tried a number of other treatments, so-called treatment-resistant depression. Now there are ongoing studies, as the question said, in addictions, PTSD. You might imagine PTSD having some similarity in terms of the kinds of anxieties to a terminally ill person. There's even some emerging research for, interestingly enough, for psychosis. You think that's paradoxical, since these potential side effect of these are hallucinogens. After all, they could produce psychosis. So now let me say this: these are highly structured and controlled scientific situations. First of all, there's a great deal of preparation for this. There's a tremendous amount that's being monitored and being followed. And the actual treatment itself is not, okay, here, take this mushroom and call me in the morning. You go into a comfortable, lovely, sweet room, soft lighting, couch, and so forth, and you're given an oral dose, low dose of psilocybin, and there is a trained, seasoned therapist who is with you and is a guide, and interacts with you and talks with you, reassures you, has a human presence, and the session lasts a number of hours. It's not like, an hour with a psychiatrist and then you go home. It's an all-day event with very, very close follow-up. So this is something that now is really not ready for prime time. It's something that's available in these very highly controlled, strict research settings, although certainly there are a lot of people, these things tend to break out on their own. Certainly there's a lot of black market availability of psilocybin. There's at least one state now where it's not illegal, despite the fact that the FDA controls it, which is Oregon. It's not illegal in Canada. People get this stuff shipped across state lines and national lines. People are using it off the books, determining their own doses and so forth. This is absolutely a bad idea. And you can become quite psychotic with these things. And to do it in this unregulated Wild West fashion would not at all be advisable. But the fact is that as we see these effects, it opens the door, don't you see, to new ideas. Okay, so how is this working? What actually is the part of the psilocybin molecule that is the active ingredient in this? And how can we perhaps modify that molecule into a safer, less hallucinogenic medicine? And by the way, there's been some very interesting studies showing, do you have to have a dissociative hallucinogenic experience for it to work? So is it just, you get people high and it's getting high? It turns out, no, it works independent of, whether people have an intense trip or not, completely independent of that. So that's not the medically active ingredient is the trip. And as I said, not everybody gets a trip. But so how can we use this to further research what's the mechanism of action? What's the neurochemistry behind this? What are some of the brain systems that we might now be able to tickle with some new pharmaceuticals that we can develop? With LSD and psilocybin have a lot of structural similarities, and they're both hallucinogens. But it turns out that if you add a bromine atom to LSD, which is brominated LSD, it does not have hallucinogenic effects. So now the next thing is, all right, why don't we do some research with brominated LSD so that we can kind of guarantee that we're not, risking psychosis in people who are taking this, and maybe that can be, another avenue of research. And meanwhile, pharmaceutical companies are paying close attention, and they're molecular architects, are building new synthetic versions of these things and trying it out. So it opens up a spectacular possibility. Perhaps somewhat related to this is ketamine. Now, ketamine, which is actually a general anesthetic that's used for children and horses, that in low doses, when you give it either intravenously or intranasally, can have a very rapid antidepressant effect, and particularly an anti-suicidal effect. And in fact, it may actually be very valuable in emergency rooms where people come in acutely suicidal, to give them a nose spritz of ketamine to turn around their suicidality, so you don't have to admit them to the hospital, because suicidal thinking and suicidal behavior is one of the most common reasons that people go into an inpatient environment. So ketamine can be useful in that situation, but there are now ketamine clinics where people can go and get a series of ketamine infusions. So ketamine taken in higher doses is hallucinogenic if it doesn't put you to sleep first. And in fact, some people who get these ketamine infusions have some trippy experiences. Not everybody, but they have some trippy experiences. So that is ready for prime time. That is on the market. It can only be given either intravenously through an hour-long infusion, or with the nose spray, and you have to stay for 2 hours to be monitored afterwards. So these are some of the new avenues that are opening up in and around these novel substances that are now coming to the attention of scientists. And look, as a experienced, seasoned, trained clinician who's seen both wonderful things in the course of my career and misadventures in the course of my career, I tend to be a little bit more on the conservative side and say, wait for the science, wait for the development of things that are safe and effective. Don't go out there trying to find a dealer who's going to give you LSD to treat your psychiatric disorders. So do we have any more questions?
Well, there is one more that came in. Do we have any more time? Okay.
Sure. I'm here.
Okay. Since mental health issues often surface during the college years, what can we do to better prepare colleges and parents of college age kids? Lisa asks.
Okay. All right, Lisa, well, you're quite right that the typical age of onset of two of our most serious major mental illnesses, schizophrenia and bipolar disorder, are between ages 18 and 25. Is the peak onset. Not that it never occurs before or after, but that's where the majority of cases onset, right? So what's happening between ages 18 and 25? Well, typically college. And college, which with its own stresses, right? For many people, the very first big step away from home on their own, as well as the academic demands and the social demands, peer demands that happen there, and a lot of, for many people, a sudden jump in their substance abuse, where people go down the alcohol rabbit hole and the marijuana rabbit hole, and other things that are out there, party drugs, and the like. So all of these factors come together to make a perfect storm, particularly for those people who may, by virtue of their genetic inheritance, already carry a vulnerability in their family history to either a major mental illness or a substance abuse disorder. So yeah, the college years are a very, very tricky time. So what can we do to better fortify our kids going away? And which is a very big question. How to build resilience in kids is something that a lot of people are thinking about. How to create healthier peer relationships. How to educate kids about the responsible drinking, and letting kids know about family histories that put them at risk for a substance use disorder, or a major mental illness, so that they have an extra level of awareness and caution in a sense of their own vulnerability. I know you're saying good luck letting, with adolescents being able to embrace the idea that they're vulnerable. But I think that there are actually ways that you can educate kids about the fact that there are some bridges that are built to withstand a certain weight load, and other bridges that can't tolerate have to tolerate a lower weight load, and so it is with genetic vulnerabilities. I think that early intervention prior to college, when you see early signs, and I talk in my book about, I have a whole chapter of, when is it time for professional help, right? When do you need to go beyond, just a good friend, a good hairdresser, a good sister who can help you with your troubles. So to be on the lookout for the thresholds where professional help is important, because we know that, like with any medical condition, that the sooner you can get in there for treatment, the better the long-term outcome. The sooner you can prevent the further development of problems, or the complication, other complications, such as adding insult to injury by not only having bipolar disorder, but then joining a fraternity that where there's a lot of drinking going on. So the earlier interventions are better. So having helping your kids have access to treatment before they go. And these days, a lot of treaters are following their kids to college through telehealth, through frequent visits home, and also collaborating with on-campus mental health professionals that might be available. I think we have one more question, which I'm happy to do.
Go ahead.
You can read it, Linda.
Oh, okay. Could you speak about your approach to treating a patient with psychotic depression? Secondly, what is the likelihood with a relapse of the psychotic depression of the patient requiring lifelong antipsychotic therapy? This is from Matt.
Okay, Matt. So first, let's talk about relapse, right? So it turns out that about 80% of people who have an episode of major depression, with or without psychosis, are going to have a relapse at some point in their life. This tends to be a recurrent illness. Now, that being said, we don't necessarily keep people on lifetime medications after the first episode. Typically, 3 episodes buys you lifetime medication, because remember, these medications are not just effective for an acute situation, but they also have preventative value. So what I like to say is that for these relapsing conditions, recurrent conditions, that when you're acutely ill, a medication like lithium, for example, is kind of like giving someone penicillin for pneumonia. It treats the acute condition. However, when you're no longer ill and you're trying to prevent relapse, continuing lithium is kind of like giving somebody blood pressure medication or cholesterol medication. It's not treating an illness that you're having now. It's trying to prevent problems in the future, because high blood pressure will cause long-term increased risk of stroke and heart attack, hardening of the arteries, high cholesterol, same thing. So those medications, cholesterol medicine, blood pressure medicines, are preventative. So lithium in the acute setting, or sometimes an antipsychotic in an acute setting, is treating the acute illness. But then when it's over, we continue it. So it's working like Lipitor for preventing relapse or minimizing the risk of relapse or making relapse milder should it occur. Now, so I said once you've had 3 episodes of depression, that your likelihood of having a 4th and more episode is close to 100%. So, and frankly, your likelihood of having a 3rd episode after having 2 is, around 90%. So I typically suggest people who've had 2 episodes stay on lifetime medication. Now, more specifically to the question, one of the most common predictors of a recurrent mood disorder is if you have psychotic symptoms. So people who've had a psychotic unipolar depression or a psychotic bipolar depression or a psychotic episode of mania, those people are extremely likely to have another episode that includes a psychotic symptoms. So the fact of the matter is that I talk to people about this, and I tell them about it and say, look, first of all, when I first start people early on in their course, I usually don't say, you need to take this medicine for the rest of your life. Because first of all, I can't be 100% sure of that. Secondly, it's a scary thing to hear, right? And who knows what the future is going to bring, and other kinds of treatments that are going to come along that may be more curative, or, a single dose, I don't know, psilocybin guarantees you'll never have another episode again. So I'm not going to tell people early on, you're going to need to be on the medicine the rest of your life. What I do say is, look, because of these features, I think it would be prudent to continue this medication, because you are really likely to have this happen again, and we know the medication can be preventative. Now, by the way, if we're talking psychotic depression, the maintenance to prevent relapses of psychotic depression do not have to necessarily include an antipsychotic, lithium alone, or Depakote alone, or trileptal, oxcarbazepine or Tegretol, lamotrigine alone might be sufficient. So just because you have had a psychotic episode, the long-term preventative treatment, which is really worth thinking about if you've had even one psychotic episode, if it's a depressed episode and it's clearly part of psychotic depression, as opposed to something that may look more like schizophrenia, and sometimes it's hard to tell, they can be maintained. sometimes quite well on just the mood stabilizer like lithium alone. They don't have to be on, Risperdal, Zyprexa, Geodon for the rest of their lives. It may be enough to just to be on a mood stabilizer without necessarily an antipsychotic. So I probably over-answered that question, but hopefully there's enough information in there for Matt. So are we at the end of the line here?
We have no other questions. I think Alita just wanted to let you know she bought your book on Amazon while we've been in the session. But thank you so much for being so generous with your time.
You're welcome.
Learned a lot.
Obviously, I have a lot of passion for this kind of education, and I hope that I've given the folks out there, both the questioners and the listeners, enough information to make some kind of difference for themselves or their loved ones. So for those of you who've stuck around to the bitter end, I thank you for your attention.
Yeah, thank you. And for the audience, if you need CEU credits, please make sure you fill out the survey that'll pop up at the end of this session, because otherwise you can't get the credits. So that's it for today. Thank you so much, Dr. Komrad.
Thank you so much, Linda. You were a big help in reading the questions, and thank you to the technical team.
Yes, thank you, Kashana.
Thank you, Kashana.
All right, and good night to everybody.
Good night. Take care, everybody.
Bye.
Stay well. That's doctor's orders.